We have an exciting program tonight. We have two ladies that presented to this academy a number of times, and by popular demand, they're back again tonight. I'm so excited as founder of this academy to be able to bring a dentist and a physician deeply committed to us working together. I think you've all have heard me share my concerns about how that doesn't happen so easily around the world. And so we're just hoping that we can continue this collaboration for the benefit of everyone across the country. So welcome, folks. Dr. David Rawson, president and founder of the Academy. Tonight, for those of you who've been with us, we'll recognize and appreciate that we are able to get Dr. Manisha Witmans, a physician, and Dr. Tammarie Heit, a dentist, who work very closely together out west. And tonight they're going to speak on sleep disordered breathing in pediatrics and the importance of synergistic collaboration, a case presentation. Because they've been with us before, I'm not going to waste their time by reading their resumes. It's published on our website. You've seen it in the flyers. So without further ado, ladies, welcome back. Happy New Year. And we're looking forward to another great presentation. Take it away.
Well, thank you. What a nice introduction. I'm Tammarie.
I'm Manisha. Thank you again for inviting us back and for the very kind introduction.
So basically, we have to give our disclosures, and I was a nurse for 10 years. I've been a dentist for 25 years. I am an integrated clinical advisor with Vivos, and I have a mastership at ICMO, and those are my kind of biases. And here we go. I'm admitting people.
Perfect. Hi, I'm Manisha. I've spoken to you before. I'm a sleep medicine physician, and I was on the clinical advisory board for Vivos, and Dr. Heit and I have worked together for a while. And as I better understand what dentistry does, I'm doing more and more work with dentists.
So our presentation is sleep disordered breathing in pediatrics and the importance of synergistic collaboration. And we're going to be talking a lot about prevention. So the 3 pillars of health, and this is just a little image from Tufts University, are basically diet, activity, and sleep. So if there's a problem with any one of those 3 pillars, that affects the overall health.
Perfect. And think of it like the tree. So the limbs of the tree or the root of the tree consists of diet, activity, and sleep. But the foundation of where that is grown or planted, if you will, makes a difference. So if that scaffolding, the foundation is in marshland, or say in the Arctic, or versus, in Alberta or even Ontario, it'll depend on what else is going on. So we talk about nature and nurture, and inflammation impacts all of that, and is fueled. Inflammation fuels the burden caused by diet or lack of activity or lack of sleep, or vice versa.
Perfect. So many of you may know that in dentistry, we can clinically reverse sleep apnea, and the sleep apnea is diagnosed and then undiagnosed by a medical doctor, and they use a sleep study to do that, in addition to getting a history and an exam. And so what we can do as dentists is do a sleep study, do whatever it is we do, and then do another one. And then when the apnea-hypopnea index is below 5 for adults and below 1 for kids, then we can collaborate with our medical doctors to see if we've reversed it. So we just received FDA approval for a dental device to treat sleep apnea. That's in the States. But a really good book that I think I personally think everybody should read, it's easy to understand, is Matt Walker's Why We Sleep. And that kind of give you a little base coat. At least that's where I got my base coat on how I can sort of approach this medical issue without getting too lost in all the diagnostic part. So
Oh, yeah, sorry, we're
sorry.
pitching and catching back and forth. So Dr. Doug Kirsch is the past president of the AASM, and he wrote a beautiful editorial. If you want to look it up, here's the reference, and we'll send you specifics. And he basically outlined disruption in healthcare and sleep medicine, quoting the song, "It's the end of the world as we know it. Please don't ask me to sing, and I feel fine." And basically, his bottom line is that we want an OSA treatment that is simple, affordable, comfortable, non-invasive, and effective for everybody, no matter who walks through the door, and accepted by most patients. And as we go on this journey of treating sleep apnea, it's a collaboration between the patient and the clinician, be that clinician a dentist or a sleep medicine doctor, about what the best approach is to optimize sleep and health.
Yeah. So our holy grail right now is the one on the left. It's something, but the 6 main components I always think about in dentistry, because dentistry is expensive. And there's downsides and upsides to everything, but it's got to be simple. It's got to be affordable. It's got to be comfortable, non-invasive, effective for everybody at all severity levels, and accepted by most patients. And in my experience clinically, the best way to get closer to that holy grail and kind of decorate it, if you will, to get this nice one over here, is to collaborate with medicine. So we can each contribute in the best way possible for that person. So we're going to give you a call for reading now, Manisha and I, and it's this special issue of in Children's Journal.
It was just published this past year. There's 17 different papers outlining all aspects of pediatric sleep apnea that you'd want to know about. I will, send the links to Bianca, and you can access all of that. It's free online. It's not pay-per-view, and it'll give you an idea of all the things we talk about and with the latest and best in what we know so far.
Yeah. And I hope you have your phones ready. You can take pictures of any of these slides if you need to just type the titles of things into your phone. But of course, you have to read this article out of this journal. It's the one we wrote, and all the doctors who wrote it are on there.
The idea behind that is that we want form and function, so structure and function, and optimizing the airway. Dr. Heit can tell you way more about that, and this is her specialty. But my job around that is to make sure that the person is healthy and continues to be healthy, and there's not other medical things that are impacting the airway or compromising it from functioning optimally. You guys address the structure, the bones and the teeth and the box, as we will outline for you in this talk, and I address the other things that might influence that.
Right. So to catch up your information on this topic, whether you're a medical doctor and a dentist, everybody has a different way of learning things. So a lot of medical doctors need a paper like this. And, this paper has I think 90 references, and they read through all that. I feel like as a dentist, I'd like to read a comic strip to learn about stuff. And I liked Matt Walker's book because it was entertaining and fun to read, and it was kind of easy to read and relaxing. So I think reading both of these, all the articles in this journal, in this special edition, and those books are really great. So from a dental perspective, I'm going to say the teeth and the jaws are like a garage, and the tongue is like a car. So that's a nice clean garage. Doesn't look anything like mine. Anyway, if the upper jaw is too small, there's not enough room for the teeth. And so the teeth are crowded. So any dentist or medical doctor can look at a person, and if they have crowded teeth, you got to think this upper jaw is too small. And part of that upper jaw is this nose hole. And so if it's too small, there can be a nasal obstruction or upper airway resistance, which we know is a precursor to the disease sleep apnea. So you can tell if the teeth are crooked. The problem is dentists are so good at making smiles that a patient goes to them for crooked teeth, and the dentist will straighten them all, They might take bits of tooth structure off so they can fit in that small jaw, or they might actually take whole teeth out so they can fit in the small jaw. So it's not just about crooked teeth. Sometimes it's masked. But if the top jaw is too small, then the bottom jaw is going to be too far back, and you'll get even more crowded teeth of the bottom jaw. So if you're a medical doctor and you look at the top teeth and they're straight, you could look at the bottom teeth too. And if those are crooked, then you know something's up, because all those bottom teeth have to fit underneath those top teeth. But if the jaw is pushed back, then it's going to close the airway in the neck. So anatomically speaking, there's the nose hole. We want people to breathe through the nose where the air is warmed and filtered, with their lips sealed, tongue up in the palate, a fully developed upper jaw, and the bottom jaw can come forward. So if the bite is deep, meaning the top teeth overlap the lower teeth, then you've got a garage with a 5-foot ceiling. If the arch of teeth is very narrow, you have a 1-car garage. If a person is obese and their tongue gains weight, you may have a normal garage, but the tongue is too big for the garage. So you can kind of think of it simply like that. But in dentistry, what we've proven is that we've grown the bone volume of the maxilla by 1.8 cubic centimeters of bone volume, which resulted in a 2.5 cubic centimeter increase in nasal airway volume. Here are the publications for that. And that change in anatomy has resulted in the reverse of sleep apnea. And so what we're in the process of doing now is showing what's unique about a particular method in doing this. So here's a cone beam CT that's now available for dentists. I've had one for 10 years. I've had 2 now. Unfortunately, the folks in Ontario, general dentists, can't have cone beam CT yet, but they're really creative. They're getting together with their radiologists and medical doctors close by so they can get the scans. But this is a picture of the same patient. And basically, this bottom jaw is too far back, making the airway quite narrow right back here behind the lower jaw. And if we put bite registration between the teeth and the bottom jaw comes forward, we can see this airway opens without changing the posture or anything. So dentists are really loving this view of the airway. Of course, this depends on positioning and swallowing during acquisition and a bunch of things. You can see the bite is deep in this one here. The bottom teeth are way up on the neck of the top teeth, where it's not as deep in this one. So just small changes in the front can result in a fairly significant change in the back. And even some dentists can do a 3D milling of this patient's airway before and after treatment to show their patients what they've actually gained. And that milling looks like this. And this is an example of a 9-year-old girl who, before we were treating her, had an apnea-hypopnea index of 18.9, and that's pretty severe.
Very severe for 9, yep.
Yeah, and then after treatment, her HI was 0. So this patient just looked like a regular person, a regular kid. She wasn't, there wasn't anything weird looking about her, except that she had crowded teeth. And then when we treated her, her teeth were no longer crowded. Her airway anatomy changed, and her metrics to measure that anatomy changed to affect her sleep.
And she didn't have her tonsils or adenoids removed. This is just with Dr. Heit's work. So basically what we want to do is make sure that the garage, as Dr. Heit said, is big enough. And that garage being big enough has implications for everything else. Think of it like the straw being pinched off, or the neck of a bottle being pinched off. For those of you that might be enjoying a glass of wine or even a decanter of wine, it makes a huge difference. If the top of the bottle is really small, it's impossible for the liquid to get out and for air to get in.
Yeah. So you can think car and garage, or if you're Felix Leo, you can think about a 6-foot tiger in a 3-foot cage. This is also a really fun book to read. So I'd recommend that. But anyways, I'm going to introduce you to this patient that Dr. Witmans sent me. She was referred, this patient was referred to me back in 2020. And the chief concern was just airway issues. He's 11 years old and 11 months. He is 4'11", 175 pounds. But by the time he came into my dental clinic and I weighed him, his actual BMI was 35.9 as opposed to 35.3. So if you're a dentist, just invest in a little scale and get the patients to actually step on it, because these kids grow really fast and change, and their reported metrics are sometimes different than their actual metrics. And so, Doctor, this is his history.
Yeah. Let me just walk through this because this is so interesting and it'll build on the rest of the presentation. So he was well at birth. Dr. Heit would ask all things about breastfeeding and, latching and tongue tie and all of that. Well, and I didn't. He had a viral illness in 2009. He had already had myringotomy tubes. So that tells me in 2010, he already has upper airway dysfunction, eustachian tube or something else. And then I didn't see him till age 4, where he was referred to me for big tonsils and adenoids. And he also had another viral illness around that same time. I sent him to have a TNA. Remember, this is 2012, or 10 years later. I've learned a lot, and now that has not been my approach, and I'll explain why. And I lost him to follow up. In that time, he developed food allergy that was confirmed. We talked about inflammation in terms of diet. He also got bronchiolitis. He had prednisone, so lots of upper and lower airway issues, ongoing milk allergies, often respiratory related symptoms. He got dexamethasone, so more steroids that makes him even fatter, or more obese, if you will. And I didn't see him until February of 2020. And I thought, my God, I don't think he's ever had relief after his tonsils and adenoids. The journey just continued. He was a train wreck all along. We just didn't know. And now I just say, look, if they're not pristine, perfect after their tonsils and adenoids, they need to see someone like me or Dr. Heit or some airway person that can help them. So when I saw him, we corrected his asthma and allergies, and I diagnosed him with sleep apnea. I tried him on CPAP. He failed, and thank God for Dr. Heit. He is obese, he has migraines, reflux, malocclusion, all these different things, and CPAP didn't work. So I was like, okay, now I don't know, and he's not quite old enough for a MAD. But, if we look at that concept of expanding the airway, can we do that? Myofunctional therapy, there is some emerging evidence that all that does help even in children. So I said, Dr. Heit, please help, because I can't fix his teeth or his garage.
So, and I more frequently go to her with that request. So it was kind of fun having it the other way around. So that was the history she sent this patient to me with. And then I did an extra oral exam. So his cervical range of motion was within normal limits. And I think of a children's stack of blocks is how I visualize the human skeleton. And if you pull one block out one way, something's got to come out the other way for everything to kind of balance. So the top block is the teeth. The next one is the TM joints. The next one is C1, C2, right down to the floor. So if he has a small maxilla and his teeth are crooked, his bottom jaw is back, that's where it starts. So it can affect the range of motion of his jaw as well as his cervical range of motion. So that's why I check and document cervical range of motion. Then I checked his vital signs. They were within normal limits, except of course his BMI. And his jaw range of motion was slightly, deficient. 40 millimeters isn't bad, but it should be 50. And then when I palpated his muscles of mastication, they were not within the normal limits. And the mother's sitting in the room as I'm palpating these muscles, and he's giving me these responses, and she's just like, didn't know that he had sore muscles of mastication. So they were severe in the areas of intra-auricular and lateral TMJ capsule and posterior to the digastric, the mastoid process and stylomandibular ligament area, the occipitals, and the trapezius muscles had a moderate response. So what that tells me is that he has kind of forward head posture. He's holding this 40-pound bowling ball ahead all day long, trying to open up his airway. He just does that automatically. and his neck and traps are sore at the age of 11. He has obstructed nasal breathing. So take the tonsils out all you want. If you don't start breathing through your nose, you know, that's why the tonsils and adenoids are probably big in the first place. It's mouth breathing because of obstructed nasal breathing, because maybe that nose hole is anatomically a little bit small. He had a reversed swallow. And so you can kind of learn about the swallowing and what normal looks like. Normal looks like nothing. Like if a person's swallowing and they don't have a problem with their tongue, you shouldn't even be able to tell they're swallowing. But some of these kids will use their whole face to swallow, or they'll just use their neck. And you can see what a reverse swallow looks like. Some really little kids will put their arm over their mouth to swallow because, you know, mom's always telling them, you know, don't be such a messy eater and stuff. And they're actually using their appendages to help swallow their food. Because, you know, if the tongue is tied or if there's aberrant tongue posture, then, you know, a person will eventually figure out to swallow so in a way that's socially acceptable, but they have to learn. So I'm going to be looking for a tongue tie. Of course, then I check cranial nerve evaluation, which isn't to the level medical doctors do, but I just learned, watched some YouTubes and found a really quick, efficient way to do it because I get so many patients coming to me with headaches. Sometimes they haven't even seen a medical doctor yet, and I don't want to, you know, move on with some sort of dental treatment when they might have a brain tumor or something weird. His tongue was enlarged in the posterior and narrow in the anterior. So that's another sign of a tongue tie or an aberrant tongue posture, because the muscles are, and the shape of the tongue is being affected by some muscles being used more than others. The tongue should be a nice, even round shape, just like a nice broad upper jaw arch of teeth. Those two should match. But if a person has a small front of the tongue and a big back of the tongue, not only does the back of the tongue obstruct the airway, but it creates that same kind of upper arch, which will throw back the lower arch. And you can feel these restrictions underneath the tongue. So you can't tell by just looking at a lingual frenum. If you get patients texting you and saying, is this a tie? You can't tell. You have to feel it and you get experience. I'm actually teaching an infant frenectomy course in Toronto in February. Manisha is going to be talking there too. And we're going to really learn how to evaluate tongues and who's tied, who's not, what's a full release, all that stuff. But when the tongue is enlarged, it's scalloped, frequently fissured as it's trying to fold into this narrow garage. And many times in this case, he had loss of tone in the soft palate. The uvula was within normal limits. The tonsils were not there. The tonsillar pillars were within normal limits, but there was a very marked gag reflex. So he, it was really bad. Like to even do his exam was tough. So Dr. Witmans' diagnosis.
So it's tag team, right? I only do the medical stuff because even what Dr. Heit looks at has been instructive for someone like me, because I have a better appreciation what the medical things are, but or what she would look at from a craniofacial point of view or craniofacial dysfunction or whatever you want to call it. So I medically diagnosed him and he couldn't tolerate CPAP. I was like, we need more to do. And his Malin Patty was almost 4. And then Dr. Heit has her own diagnoses.
Yeah, so my first one is possible sleep apnea and or upper airway resistance without diagnosis or treatment. And I always use the word possible in my dental diagnosis because as a dentist, we should not diagnose systemic disease. We're not trained to do that. We're only trained to diagnose this here. So I like to leave that to the medical doctors. Patients get better care that way when that diagnosis is considered. So possible is the word I use. And that enables me to just, refer to the doctor, get a sleep study, whatever. Second, diagnosis is maxillary deficiency. His third diagnosis was mandibular discrepancy to the cranial base. And because he did have headaches and stuff like that, he's got craniomandibular disorder and all those signs and symptoms that we see that are not normal. So in a normal kid, should look like is a kid whose jaws are big enough to eventually fit all 32 teeth without getting braces and without getting their wisdom teeth out. And that's optimal. And we should really shoot for that. We're not used to looking for that because the other is so common. And then he had moderate general gingivitis and this aberrant tongue posture with a posterior tongue tie that's resulted in a change in the shape of his tongue. And he had a class 1, I'm going to say malocclusion, because both jaws are set back. And some of I think they're even making a class 4 in orthodontics to recognize sort of a class 1 tooth alignment, but where both jaws are set back. That's kind of a sleep diagnosis. So that's a kind of the dental section and we're adding to the diagnosis, which is what referral is all about.
Okay, so if I were to think of it, when I think about sleep apnea or breathing or sleep and health, there's 5 goalposts we want. We want sleep to be great. We want breathing to be great. We want them to be able to eat well and grow well or develop well. Any aberrant in either way, either too much sleep or too little sleep or breathing too hard and fast or not enough, all the rest on either side is a problem. And I can do so much from a functional point of view and inflammation, and then you all help us make the other parts more perfect.
Yeah. And what's really cool is when I was talking to my friend Felix the other day, he said, you know who the smartest one of all is? It's Mother Nature. She knows what to do. She sets things up and you throw stuff at her and the body just accommodates.
Yep.
So this whole way of using this device, and you could try this with whatever device you love, is really respecting Mother Nature. Think of it as a splint or a crutch that you're just using for a temporary support so that the body can grow and function in a better way.
And the importance of this is going back, we've known about sleep apnea since the 60s, but the first descriptions way back in the 1800s and even before then. What we have learned over the last 30 years about sleep apnea is that there is devastation. There is end organ dysfunction from that garage being too small, whether it's ADHD, not being able to learn, an adult not being able to keep a job, even adult ADHD, performance deficits, long-term sequelae like diabetes, obesity like this boy, cardiovascular dysfunction, left ventricular hypertrophy, hypertension. It is not minimal. It is profound and significant and life-altering morbidity and mortality.
And you can find it in kids.
Yep. And when I think back in the last 20 years, I've been working for a while, I used to line up all these kids for tonsils and adenoids. And what the literature shows is that the resolution from a TNA is only 27%. Our prototype case that we're talking about is a TNA. And sure, it helped initially, and it made a little bit of a difference, but not really. And I wish now when the kids are that little, I treat the inflammation, I address the diet, and I address the stuff early on. I say, okay, I'm going to send you to the ear, nose, throat doctor because they're going to decide if the tonsils need to come out, but I'm also going to send you to an airway dentist because I want to make sure that that garage and that airway is big enough. Because if we can do an expansion, or depending on the age of the child or whatever you guys do to make that airway bigger and better, I even send them to my functional therapist. I even teach them nose breathing exercises and nasal airway clearance, all of that. And so if we don't stop the runaway freight train, like in this boy, obesity is an inflammatory condition as well. It increases risk for OSA. The sleep apnea worsens as obesity. The sleep apnea worsens asthma and allergies. The sleep apnea worsens his end organ dysfunction like diabetes and bidirectional. And it's important to address the inflammation and allergies and underlying nature of what is going on. I haven't even talked about trauma and the implications of trauma and how that might influence the environment that further adds to the inflammation that's going on.
That's it. And
so anatomy can also help. So it's best if our exam is done in parallel, if you will. Dr. Heit looks at all the craniofacial stuff. And then there's kids together that we have diagnosed with genetic syndromes or discussed their craniofacial profile. And it's linked to many other things like Altes and Ehlers-Danlos and all sorts of things. And it increases the risk for obstructive sleep apnea when you think about Down syndrome and, Treacher Collins or cleft lip and palate, all these things. When we put all of that together, it's a problem of form and function and compensation.
Yes, and I think if we throw Mother Nature a bone, if you want big muscles, what do? You do weights and your muscles get big. If you want your nasal airway to grow and you want this area to optimize, you can do things like Buteyko breathing, myofunctional therapy.
Yeah.
You can put a little device in the mouth that stimulates the nerves and stuff that go up to the brain and the whole biofeedback system. And you can, as a dentist, it's pretty simple to design this thing once you learn how. And then the kid just wears it and they fix themselves. And the cool thing is if the tongue is actually responsible for growing the palate, what are the chances it's going to stay there and you don't have relapse like we know about with orthodontic movement of the teeth?
And it speaks to that root cause. So with all the myofunctional things that Dr. Heit just spoke about, it's important to address the root causes of inflammation. Her and I together, we've diagnosed kids with celiac disease. We've diagnosed restless legs. There's actually 64 sleep disorders. OSA is only one. Sometimes they present with bedwetting. Sometimes they present with sleepwalking, whatever it is. And as we work together and expand their airway, it's amazing how many things correct themselves between Mother Nature doing her job, which is growing the airway naturally. We just help things along and take away the things that might make things worse. And voila, you have a kid that feels better.
That's it. And I love that you brought up the word bedwetting, because how about doing a clinical trial on bedwetting kids? We can treat the bedwetting kids with a dental device, and then we could measure some of these anatomies to see the impact and the metrics. And
so we looked at that with the Vivos appliance from their registry, and what one of the third-party researchers, she reviewed the database and showed that primary enuresis, which is bedwetting, is cured quicker with a guide, a Vivos guide, than spontaneous resolution, which is 15% per year. And in 120 days, and a kid that's bedwetting beyond age 5, if Dr. Heit can tell you all the details about that. Remember, I'm not the dentist pro here. That you can actually improve bedwetting, and there's actually medical, physiological, and hormonal reasons for that. I can explain that another time, but it's pretty cool that just making sure that you can nasal breathe, and with your support from a dentistry point of view, we can fix the bedwetting in less than 3 months.
yes, so this is more recent. With these, by this collaboration that we're doing clinically, we're bringing it up by gathering actual data. And this is where my background as a nurse comes in. I'm used to writing things down and taking a lot of notes. I have thousands of pages of records, but the girls do it. And so when you have that data, then you can support some of these things. And that's where, we've written this article in this journal to show that there's a disease, the prevention, early recognition, and reversal of suboptimal development of the mandible and maxilla, and the compensatory dental function leading to disease may be a very important paradigm shift compared to treating disease. So that is a paradigm shift that starts with collaboration and continues with collaboration. So it's super important that medical doctors get together with dentists. Like, I think the American Academy of Sleep Medicine should have the same meeting together with the American Academy of Dental Sleep Medicine. It should be one big meeting for everybody. And that's what we're doing. So some great advances that have been coming along. When I did the clinical trials, which the FDA have accepted the data, and they go through this rigorous testing. We were doing NOx-T3 studies. So take a look at this little girl and what she's sleeping with there. She's got something on her finger, a couple straps around her chest, something in her nose, but they're able to do a home sleep study and sleep in their own bed. It's better than in the hospital. But, you know, now it's really important to be able to do sleep studies.
Yeah, and when we're looking at this, it's been shown that going back to the previous slide where Dr. Heit told you that early prevention and early intervention is important, this study actually showed that treating them early improves behavior in childhood and improves their school functioning. If you go back to what Dr. David Gozell showed in '98, when they looked with oximetry and evaluated for sleep apnea and did a adenotonsillectomy, the parents' choice, and looked at them the next year again. So this was the 10% bottom functioning children in grade 1, their IQ increased by 12 points, by grade 2, 12 points. So we should start early.
That's it. So I want you guys all to look at this gorgeous woman here. Her name is Solveig Magnus Jochair, and we just call her Sola. And this is somebody that Manisha and I know very well. And I could just kiss her all over because she made me a ring that can measure sleep apnea in kids. And this ring is very accurate. It compares to level 1 sleep studies. It can, because it's just a ring, it can give you sleep quality information, and it's great for adults, especially adults. What I find a lot of adults are coming to me for is just to get rid of migraines, and some of them don't have sleep apnea, but when you test them, you can see their sleep quality is bad. They have a lot of fragmentation and stuff like that. So we actually have some metrics that can correlate with the improvement of the report that the patient gives you, the subjective evidence. Yes, my headaches are better, and now we can use some data. So this is sleep image technology.
Yeah, it has a concordance rate with an overnight polysomnogram to be 98%. It's validated in age 2 and up. But it is one piece of the information, right? Just like a CBCT or an X-ray or whatever. And she said this, and it's so true. And we live by it because we ask each other and measure the data. Where, you know, in Ontario, you're all blessed to have an overnight polysomnogram, and as are many other places in the US. But in Alberta, we're in the land of ambulatory testing, and PSGs aren't readily available. And this has really improved our access to objective information that is so important. And she aptly said, ask the patient, the answer is in their story, and the data is used to connect the dots to plan treatment. So the sleep image tells us what is going on, whether it's sleep quality, sleep fragmentation, sleep apnea, and then the two of us work together to both improve the sleep as well as improve the airway.
That's it. So I want you guys all to take a picture of this here. This is a website called thescienceofsleepapnea.com. And in the middle there, episode 5, there's Sola, and she's talking about this technology. So this website has 12 of these live broadcasts, and a couple other examples. We have primary care physician, Dr. Sanjeev Jain from Toronto. And then on the other side there, we have Dr. Cooler. He's a psychiatrist here in Edmonton, but we have a cardiologist, a neurologist, an anesthesiologist, ENT, all these different doctors that are learning about this, what dentists are able to do to change the anatomy in people and affect their particular specialty. So this is a huge sort of, I guess it's an unveiling, even for your medical doctors. They like to hear it from their own kind. So get the ENT to watch the ENT version of this or whatever you want. But it's just like trying to get medical doctors and dentists to collaborate. So this is my patient here with that little thing on her thumb, and she's 2. And for me to be able to measure when I see some craniofacial thing, just to see if she has sleep apnea or not, is really powerful, because then if she does, you know, then I can send her to Manisha and she can get some proper treatment.
Yep, and depending on how severe it is or what's going on, we send them to the ear, nose, throat doctor if there's tonsils and adenoids. But again, remember, it's not just tonsils and adenoids, it's whatever is affecting the entire airway. And this sleep image device has been validated in kids as young as 2.
Yeah, and comparable, it says right there, comparable to manual scoring of age high from in-laboratory PSGs. Yeah. So cool, save money. It's cheap to do this. this is what the sleep study looks like. And so as a dentist, I'm not going to, look at this and diagnose it and tell my patient. I tell a patient, hey, this is got to be read by a board certified sleep specialist. But I can tell you that green is good, yellow is caution, and red is bad. And then the one on the left has 2 greens and 6 reds, and the one in the right looks a little better. And so, I can use this to measure if I'm going the right direction with the patient. And if one of these sleep studies comes back all red, then I'm starting to think, well, maybe they need to go back to Manisha, and then she can read the actual stuff that she reads.
Yeah, I read these for the dentists that do them, and then depending on what it is, it provides some guidance. It is very complicated. Think of a math problem that has like brackets and square signs and square root signs and division and whatever, and you have this hodgepodge complex equation, and it spits out this beautiful report. There's a lot going on, and I have done presentations that explains this in more detail. I'm happy to share that with you at another time.
Yeah.
But we'll keep going.
So what we need is someone to read these reports and make it all official, but that won't be me.
So there was a study that they did. This was a retrospective review where they looked at the sleep quality and sleep apnea and metabolic health in children who had an adenotonsillectomy. So this is a secondary analysis. And we wanted to see, you remember the CHAD study? I spoke about it before, the childhood adenotonsillectomy study, and we showed in that, what they showed, sorry, not we, in 440 kids, 46% of kids normalized with their PSG in a watchful waiting group. Crazy, like 7 months just sitting idle, doing nothing, your sleep study normalized. That is because there's so much growth between that 6 to 7 year age mark, right? Remember, the kids grow 6-7 centimeters per year. It's a lot. It could impact the airway. And basically what Sola and gang showed, that when we look at that children that have really good sleep quality and mild sleep apnea, they might not benefit from the adenotonsillectomy. So if they don't benefit from the adenotonsillectomy, the question is their problem is the size of the garage more than the tonsils and adenoids anyway, and we should address that garage and take into account what their sleep quality is like, because it might have a bearing on their metabolic health and their overall health and well-being.
Yes, and if there's some evidence to say that a procedure isn't as effective as sort of it's supposed to be, then
Why do it?
the risks of tonsillectomy and adenoidectomy are going to start to outweigh the benefits. And one of the risks is the general anesthetic and death. Parents got to sign that.
Yep.
So we need to determine how to manage the millions of patients with undiagnosed sleep apnea through this collaborative care models and primary care providers and other specialists. And we got to really leverage this disruptive technology that we use to try to measure sleep. So the treatment options for this patient that I showed you then was to do a sleep study, refer to the MD, and then we're going to try myofunctional therapy on him for tongue evaluation and therapy, because he had such a strong gag reflex. How are we going to put an appliance in there? We sent him to the hygienist for teeth cleaning. And then I decided a Vivos Care for maxillary deficiency is the choice, because he has sleep apnea, and to collaborate with the medical colleagues, because the medical conditions can also affect form and function. So the choices I have are rapid maxillary expansion, a mandibular advancement device, myofunctional therapy, the Vivos Care, but there's lack of up-to-date evidence for treatment and conflicting evidence in the literature, and lack of real clear answers to some of these clinical questions we have, like what do we work? What are we going to use that works? So
so part of why this actually, I have Dr. Heit involved very early, even in 3, 4, 5-year-olds, is because I don't want these kids on CPAP. Pressure and time affects everything. Pressure and time makes cold diamonds. Pressure and time would make your mid-face deficient with CPAP. So, and the compliance isn't very good. And he was intolerant of CPAP, and you saw how big he was, and he was on the trajectory of morbidity and mortality. And because of the concern on craniofacial impact, look, CPAP is effective. It really works, but the newest data from ESRS shows that it has to be a collaborative decision between the patient and the treating clinician, because long-term CPAP wouldn't work. And that makes sense, because if you have a reduced nasal aperture and a reduced garage, the CPAP's only helping at night. What do you do during the day when you have headaches and an open jaw and can't breathe through your nose, and you eat funny and you breathe funny and you smell funny sometimes? All those things still need to be dealt with. So in the spirit of having the optimal garage and the optimal airway, we want to address everything and treat the root cause.
So now this evidence of non-inflammatory protocols is starting to emerge as beneficial for bone development in the craniofacial region. So rapid maxillary expansion is not non-inflammatory. That hurts. So whatever treatment you're doing as a dentist to develop the maxilla, it's got to not hurt. And so the results so far in this patient was that the myofunctional therapy reduced the gag reflex enough, and now is time for me to try the novel dental device. So myofunctional therapy in this particular case gave this patient the ability to have a dental device. So the dental device was presented in 2022. This particular dental device, the Vivos Care device, at 4 of the world's biggest and most scientific meetings, and it has the best research and peer-reviewed publications. And so the first one was at World Sleep Society in Rome.
Yeah, it was a beautiful meeting. There was over 2,000 people there. And here's the DNA appliance that you can see. And it does indeed reduce sleep apnea. We can send you the posters if you like. And then Bianca can post them on the site. But it does work. It works as well as other devices. And if you use it, it can certainly help. In fact, in over 50%, it completely normalized the AHI.
So it is cleared as a mandibular advancement device. That's why we were able to use it. But what we were doing, and the reason why I was at this sleep congress is because it was actually reversing sleep apnea, and we were doing sleep studies with nothing in the mouth. And then it was presented again at the Academy of Sleep Medicine Sleep Research Society in Charlotte. So that's the poster there, the big one. And then again, the year you took it there, I didn't go to this one in Greece.
Yeah, this one is in children. It actually, if you look at the severity of sleep apnea, it actually cures sleep apnea. Again, we want to expand and actually normalize the weight in some of these kids, because when the airway and the fuel line is big enough, then there's no need for inflammation and the weight normalizes. It's pretty cool and exciting.
So you can't say cure until the FDA says it's okay. The other thing I'm using this for, of course, is our headaches. And what you need to do is a headache impact test. So if you Google HIT6, you'll see that there's 6 easy questions to ask and what that means. It's a validated study to measure headaches. So, 78 is the worst you can be, and 36 is where you want to be, and 50 is the measurement for clinical significance. So if I treat someone with a DNA who has headaches and they go from 66 to 36, I can actually measure that their headaches went away. It's a headache impact test. So if you're a dentist, you got to be using this. So on Tuesday, January 4th of 2023, there it is. This Vivos Therapeutics received FDA 510(k) clearance of its flagship DNA oral appliance for the treatment of obstructive sleep apnea. So this is the first dental device that's used for treating sleep apnea as opposed to managing it, which all the other dental devices just hold the bottom jaw forward. So this is huge. And the best place to learn, I guess, would be Vivos, or I'll teach you. But here's what happened to this kid. There he is pre-treatment with his BMI of 35.3 or 35.9. I put them both in there because he could have grown that much between the time his mom weighed him and I weighed him.
Yeah.
And at the 6 months level, he wasn't able to wear it only 25% of the nights and less than 10 hours a day. So remember, he had a really strong gag reflex, and we're working on myofunctional therapy, and he's starting to get used to this thing in his mouth. And his BMI was now up to 40.2. And then eventually, when he was able to fully wear it, his body just loved it. And his BMI came down then. It started going the other direction. So we're changing this trajectory. And, you know, I'm taking these photos of the patient, I'm taking impressions of their jaws, and we're getting photos to see how he looked. So the difference between adults and kids, of course, the kids are growing anyway. So this kid is going to grow one way or another. But look at the difference in his size, and you can measure that size with the BMI. In an adult, all the heights would be the same, but this kid is getting healthier. Not only that, he was on like 9 medications when he started, and now he's on 4. He was on 3 for a while, but he's back on Zolar. Like, we just keep going back and forth with this kid. And
he's done remarkably well. I can't wait to see him. And we, you know, when we're talking about the environment that I spoke about earlier, we're addressing all of it: diet, exercise, mindset, activity, all of it, in an effort to help him get over more and more stuff to get back to being healthy and well.
And, you know, medical doctors are super good at advising their patients, you know, what to do, and they give them support and do all these things. But to see actual results, sometimes a person just needs a good night's sleep to be able to go and exercise and feel well. But this guy's like playing hockey now and doing all this stuff the kids should be doing. Everybody wants him on his team because he's so nice and tall. But the progress to date is he's able to wear the device half-time by October and 90% by April. So we started to really see results by April. His gagging improved, his BMI improved, his headache impact test score went from 66 to 60 with reduced medications for headaches. So one way it's important as a dentist, you think about when you're collaborating with your medical doctor, if a person's on a bunch of medications and you're doing something to help their sleep better, and you're measuring a headache score and it's getting better, the medical doctor needs to think about reducing some of these medications that have been supporting the patient's disease. And I've had patients go down on all kinds of medications for diabetes and thyroid and all kinds of things when they start to get better. So working collaboratively is really good from the standpoint that a patient isn't taking unnecessary medications. The biggest ones to go away are anti-anxiety meds. Those are the big ones.
When the garage is big enough, it's amazing how much fuel you get, and your breath is no longer at your throat. You can actually go to your lungs in a breath because the garage is big enough.
That's awesome. So that was a tough case. So I'll show you some easy cases. Look at the little guy in the left. Like, how many of you guys have a patient that looks like the guy on your left in your clinic? And so if you look for the signs and symptoms, like look at that active chin and that face, after 4 months of treatment with this, his metrics, he grew right into normal. We're just trying to avoid braces, but he felt better and his symptoms went away. A lot of these kids stopped bedwetting. This is what his teeth looked like. You can see he has some crossbite there, and the crossbite is improved, and his open bite's closing down. So this flower of a maxilla is starting to fully bloom towards this nice broad stage. And then what happens is when the kid is chewing, the bottom teeth start to upright to, because they're all folded in to fit with this narrow maxilla. And now they're going to start to upright to fit with the wider maxilla. And you can see I put some risers on this kid too. So 6-year molars erupted into class 1. Here's this kid with night terrors and 8 months in treatment. Look at the size of his head. Forget about his thyromandibular angle, which now is normal, but this guy grew. His night terrors went away. His sleep apnea went away. Like from a clinical point, we didn't actually measure him, but this is what happens to your kids when you treat them with this. And then, of course, we're dentists. Why do we treat them? Well, because they have maxillary deficiency. So I put the DNA in there for maxillary deficiency, and that fixed his maxillary deficiency. But now it's officially cleared in the United States, not Canada yet, I don't believe, because I doubt it. But now it can be used for sleep apnea, but you can still use it to treat maxillary deficiency, and you can see how it worked there. But this little guy had a tongue tie. And does having a tongue tie really limit the result? Absolutely. The tongue is the thing that actually grows it. The appliance is designed to train the tongue to grow it. So that tongue's got to be released to get the optimal result. And the physiologic rest position of the jaw, it's really defined as the balance between the posture of the jaw, and that's found with TENS. And I do neuromuscular dentistry. That's my bias. And I've just got a few minutes left. We'll get this one last concept. This is important, that this mandibular posture is maintained by a state of static equilibrium, which is maintained by a delicate balance of muscle forces pulling from above by the forces of the muscles of mastication, and below by the hyoid musculature and gravity. So to help you understand that, and this is how I'm talking to my patients about it now, Manisha approached me with this speaker, and she basically said, is that how the jaws grow?
Michael, actually, but yes.
Oh, is it Michael? Okay.
Major, yeah.
Oh, okay. Is this how you relate the jaws? So I went to my daughter, Grace, who's now in 4th year engineering, and I said, how does this work? And then she drew some figures and told me about forces and stuff. And then she drew it really simply for me, and then showed me an alternative way to suspend the top platform some way that I could understand. But then I said, well, how does that apply to the body? And she goes, Mom, the skeleton is just a bunch of bones. It's similar to that, but with meat and liquids. And the bones won't hold up without the meat and the liquids. So I said that to a guy today who had a problem with his meat and liquids, because pain comes from muscles. Right. And so, really your bones are just a pile on the floor without all the meat and the liquids. There's something wrong with the meat and the liquids. So I treat the meat with, I find out what the EMGs are. I get the jaw tracking to optimize everything like that. And she helps with the chemicals, the liquids and whatever. Anyways, that's just a way of thinking of it, but it is a really complex system that we have here. And patients have a goalpost that they function within, that's like just no symptoms. You've seen those patients, they don't have any symptoms, but they're all messed up. And outside of those goalposts, they have symptoms. So our job is to get them in the middle of this. So this this care process, you should read this article that was published in a medical journal about the Vivos care option. And that is how we're going to get this holy grail, is we need lots and lots of people using these concepts described in this call for reading here, so that your work can be compared. We put it all together, and we want this to be simple and cheap, and so everybody can get it. So if you can measure it, it's fact. If you can't, it's an opinion. And this data is going to be really important coming from your clinic, from you. And evidence-based medicine, this is the way. We need these clinical trials. This is the way. And Vivos is doing some studies at Stanford and stuff like that. But I saw this in the newspaper the other day. Kids with respiratory illnesses are admitted at several times the usual rate. I don't know, that might be related to the flu or COVID, but I'm just going to direct you guys. The International College of Craniomandibular Orthopedics is having a conference in Goa, India in May. If you can't make that one, there's one in Calgary. If you take a snapshot of this, you can get to some presentations on the Vivos website. And then I'm going to invite you all to our infant frenectomy course, which, wow, wouldn't it be cool if that tongue was released right at the beginning and the kid followed Mother Nature? So what does Mother Nature say? You breastfeed. You breastfeed for a couple of years. You eat hard, healthy food. That's what develops your face. And so when you're trying to fix a face that's underdeveloped, get back to those things is what I say. So you can always text me or email me at this at drtheit@gmail.com if you have questions about that.
And you have my email from before, or just contact Bianca. She knows how to get a hold of me.